Hello, everyone. Welcome to Conversations with Visionaries, a podcast series presented by Voluntary Action Network India VANI. I'm your host Subhashini Prabhakar from VANI's programs team. Our guest today is Dr. Prakash Tyagi, who is a distinguished leader in global health, currently serving as the Executive Director of Gramin Vikas Vigyan Samiti, GRAVIS, a grassroots organization in Rajasthan, India. He is also affiliated with the University of Washington's Department of Global Health, with extensive expertise in community based healthcare, rural development, and sustainability. Dr. Tyagi has spearheaded innovative programs aimed at addressing health inequities and empowering underserved communities. His work has earned him international recognition for blending traditional knowledge with modern approaches to improve the well being of marginalized populations. Prakashji, your transition from clinical medicine to global health and community centered initiatives, and how has your vision evolved over these years?
Thank you very much for having me on this program. It's wonderful to be with your listeners. The transition from clinical medicine to more global health kind of approach was not intentional, was not planned. When I started my work journey of my life in early 2000s or so, the first thing that I was assigned with was to set up a rural hospital, which I had done, which I had run for some time, which was all clinical work. And that hospital that we had established a long time ago continues to be one of the major rural health facilities where we work in the state of Rajasthan. But as I continued working on the clinical sides for some time, I very quickly realized that health is such a vast and holistic area, and it has so much connectivity with other spheres of life. And then it led me to think that how can I contribute to the larger discussions in which people's preferences, people's voices can reach the program levels, the policy levels. Health, as it is defined by the WHO, is a state of complete physical, mental, and social well-being, and not merely the absence of disease. Keeping that in view, it's important that the clinical work goes on. But beyond clinical work, there is actually a lot of aspects which remain to be unattended, poorly addressed. So I then decided that I'm going to contribute to other spheres of healthcare as well, by documenting health problems, by establishing more partnerships, and by being a bridge between communities' perspectives and healthcare programs, policies, and resource allocation processes. We have also been repeatedly, collectively voicing as a global community that health and healthcare need to be more person-centric, more community-centric than disease-centric. And if it has to be person-centric, if it has to be community-centric, then the roles of communities, of course, become more vital. And therefore, the community-centric initiatives become absolutely critical. With those ideas, those thoughts in mind, I had not fully transitioned from clinical side to the other side, but I decided that I would be better suitable in filling the gap that I saw. I wouldn't say that the clinical work is not important. Clinical work is absolutely important. And the human resource scenario in our country in the clinical work context is still quite imbalanced. We are still not having enough physicians or healthcare workers as a proportion to our population. But the same human resource shortage in the fields of public health and the fields of holistic health and global health is even more critical. So I think moving forward, there is a need of having a balanced approach in which there are adequate number of clinicians and adequate number of public health thinkers and workers and practitioners, so that we can realize the definition of health that I just stated in my comments.
So that's how it all started. Sir, could you please share a transformative story from your work in all these years that highlights the difference your initiatives have made in the underserved communities in Rajasthan?
There are several stories that are very inspiring, very transformative, and I have learned a lot from those. So I would like to narrate what we have done with occupational health as an example.
Okay.
Uh, we have we had been working with the local communities for a long time,
Mm.
and one of the population groups that is an important target group for us is mine workers. The desert region of Rajasthan is extremely rain deprived, and agriculture is the main livelihood means for people. But because of droughts, a lot of
Yeah.
times the farmers are unable to have a livelihood, and therefore they seek alternative employment options, and mining becomes the most natural source of income generation for a lot of people. However, mining is very risky in terms of health hazards, and the preventive arrangements in the mining areas are very, very poor. So about 30 years ago or so, when Gravis was doing groundwork with the local communities, it realized that there is a lot of premature mortality among mine workers, and there are a large number of widows in the community because of premature death of male members of the families, and also orphans, leading to all kinds of social problems and to poverty and to poor health conditions. Initially, the understanding was that it is tuberculosis, which is, of course, a more known lung disease impacting a large number of people in different parts of India. And we thought that this is TB, and TB needs to be addressed, TB needs to be cured, and TB is a curable disease. But then, as the work progressed, we realized that this is something else in addition to TB. And that opened our eyes to realize that there is actually a disease called silicosis, which is killing mine workers. And it's a occupational health hazard. It's occupational lung disease, which develops as a result of long-term inhalation of silica dust, which is found in stone mines and marble mines. Thousands of mine workers were suffering with silicosis at that time. Many were dying, and their families were struggling. And then there were many challenges, such as silicosis is very similar to TB, and therefore it's very difficult to differentiate the two diseases. But overall, there was no acceptance that there is silicosis. There is an occupational disease which is actually preventable. Silicosis is not curable, but it is preventable. So in mid-1990s, Gravis took this up as a campaign. Firstly documented the cases, collected the data and evidence, reached the authorities, and advocated for the cause of silicosis, stating that there is a need, there is a public health problem which needs to be immediately addressed and taken into account, so that people who are suffering can get relief, can get compensations, and then there will be preventive arrangements to protect the future generations of the local communities. Initially, it was a very hard struggle because there was denial, there was no acceptance that such a public health problem persists. But we are very pleased to see that due to the initial efforts, the advocacy that persisted over 2 or 3 decades, silicosis is now a well understood, well recognized, well accepted public health problem. And that has contributed to a lot of change. Mine workers now, I wouldn't say that silicosis has been completely eliminated, but there are better health safety arrangements in mining areas. There are compensations which are being given to silicosis affected mine workers and to their families. There is a greater awareness on silicosis, and therefore there is a greater understanding. There are more robust partnerships to deal with the disease. So that's a kind of a transformation, that's a kind of a change which can occur if there is sustained public health campaign, if there are efforts which are comprised data collection, awareness generation, and training and capacity building. So we are very pleased to see that the silicosis control program has come so far because of these.
That's a huge impact which has happened in the community. And yes, over the years, it has given a lot of improvement in that community. Sorry. While working in such health related initiatives, so collaboration becomes very essential. So, could you discuss how partnerships with governments, other NGOs, and academic institutions have amplified the reach and impact of your organization's initiative?
I think partnerships are extremely important.
Mm.
First of all, NGOs like ours and many other organizations which are working at the ground level may be doing great work. We believe that we are doing great work, but we are not the only organization. There are many others. But
Yes.
then our role is about creating models that could be replicated, demonstrating models that could be replicated, because organizations like Gravis are not capable of dealing with the population that we have in the country or
Mm.
in a state, for example, because the magnitude is big, it's huge. And
Yes.
therefore, the government programs are inevitably important. It's extremely important that the government plans are made in consultation with communities, local organizations, think tanks. And that's where I think organizations which are working at the ground level play a critical role. They are able to provide the feedback on behalf of the communities, on behalf of the patients, on behalf of local groups, which we do quite effectively. Government health departments and government health programs have also been quite proactive in the recent past in ensuring that the local organizations are a part of discussions, are a part of the dialogues when the health programs are formulated. Only with the help of these kinds of partnerships, the dissemination of new programs, new policies will be possible. Otherwise, it becomes extremely difficult in translating the policies into implementation. And we are a country which has a lot of health issues. We are a country which has a lot of implementation challenges. But we are also a country that has some very strong guidelines and strong policies which remain to be unutilized. And the potential is there for organizations like ours to ensure that the communities understand about these programs. The other kind of partnerships which is extremely important is partnerships with academic organizations, because implementing organizations may be doing their bits and pieces in research, documentation, and advocacy. But the reality is that research and documentation are specialized areas, and it's important that academic organizations contribute to that. The richer the data is, the stronger the evidence is, the better are the possibilities for scale up or for replication of successful programs and for resource allocation, which is so critical for continuing the programs that have been successful at the ground level. So these are a few things that come to my mind in partnerships context. And the other thing is that both horizontal and vertical partnerships are important. And we see a lot of horizontal partnerships like NGOs partnering with NGOs or community-based groups partnering with community-based groups, similar kind of organizations or service providers. But in the context of vertical partnerships, it's important to have different types of stakeholders in one place, one forum, in one discussion table: governments, civil society, community-based groups, and also private sector, which is so important in service delivery component in our country. And then these partnerships are important, at least in the local context, in the national scenario, but they are also important in the global context, because health is a matter which is driven by a lot of global policies, a lot of global programs. Organizations like WHO, for example, have a strong driving role, and their policies, their programs, formulation of their new ideas also very largely depends on what kind of feedbacks they are getting. And therefore, it's important for the organizations that are working at the ground level to be aware of the opportunities, to be aware of the windows where they can be an active partner in conveying the voices and connecting the dots between people's voices and how the programs are going to be formed. So there are multiple levels, multiple layers in which partnerships are important. Gravis has been very proactive in ensuring that we are a member of various partnerships, various mechanisms that are there for bridging the gaps between programs and policies. And lastly, what I would like to say is that the civil society, which is our group of people, also need to strengthen our partnerships much more deeply in the context of health. The partnerships of CSOs in other spheres of programs seems to be much stronger than in the sphere of healthcare. So that's I think an area on which more work is required as we move forward.
Very rightly said. Sir, could you please say about the recent health-related programs with which Gravis is continuing now? I mean,
Our health approach is holistic and looks at various needs, various levels of communities' requirements.
okay.
We broadly divide our health interventions into three categories. The first one is medical services delivery. The second one is about public health, education, training, and capacity building. And the third one is about research and advocacy. Within the medical and service delivery part, we run a hospital which provides primary and secondary levels of medical care to the rural populations. Both primary care, outpatient services, as well as indoor hospitalization services and surgical services. Within this component, we are also active in providing outreach medical services, which is taking the medical services to people's homes and people's villages and communities, which are very remotely located and which have populations that cannot access the nearest medical facility. So that medical and service delivery part is one of the prominent part of our work. The second component is focused on public health, which again is promotion of preventive aspects of healthcare, strengthening people's understanding of health issues, training and capacity building of various types of cadres of health workers, either trained and nurtured by us as an organization or providing support to government health workers, such as Anganwadi workers and ASHA workers, and then also specialized focus on the number of public health priorities, such as population aging, occupational health program that I mentioned in my last comment, nutrition, community-based eye care, maternal and child health. In all these spheres, we have a very targeted public health interventions and approach. And the third bit is about research and advocacy, because we believe there is a lot that needs to be documented, collected in terms of data and evidence, and compiled in the forms of publications, studies, advocacy papers, because only then the reality of the communities can go to various levels. It's important to have documented knowledge for learning and exchange between different organizations working in different settings. We believe that we contribute quite a bit to other organizations functioning and learning with the materials that we are able to produce. But we are also very pleased to receive the information from other organizations as a learning for us. So the learning and exchange on health programs is important. And then research and documentation is extremely important for advocacy, for more resources, and for replication of the interventions that we are doing. And keeping that in view, we have done large numbers of publications, either on technical aspects like silicosis or eye diseases or tuberculosis, for example, but also on general public health aspects such as gender issues, the intersection of climate change and health, older people's roles and conditions in the context of health. So our health work is very multi-layered, very comprehensive, and it is very directly aligned with the other programs that we do, for example, on food security, nutrition, water security, because there is definitely a linkage between all the aspects that we work on.
So it is a holistic approach for the health related issues and also the larger impact which you are bringing up in the society. Great. Sir, as a CSO leader, so you must have seen some significant barriers to achieving health equality in marginalized communities. So how do you address these issues?
There are barriers which are there in any community, in any country that I can speak about. And then there are India-specific issues as well, which are more relevant to our communities, our countries.
Yes.
I mean, firstly, lack of health literacy continues to be a big problem, although the literacy rates have gone up in India, globally. But the understanding of prevention, the health literacy levels remain to be very, very limited in most parts of the world, in low resource settings, in low and middle income countries, but also in low resource settings and even in high income countries. The populations that are impoverished, the populations that are marginalized, their health understanding is very, very limited, and therefore health education continues to be a very significant barrier, continues to be a very important priority moving forward. And then the specific challenges that are there for our country, for India. First of all, the demographic challenge that our country is witnessing is dual. Our population is very quickly becoming old. The numbers of older people are rising. Currently, about 10% of India's population is considered to be older people, that is 60 plus.
Correct. Yes.
But that number is rising quite rapidly and quite significantly, and will rise to to much significant numbers in the next 2 or 3 decades. So we need to be prepared for older people's health needs, which are important, of course. But at the same time, we also have a very large youth population.
Yes.
So, for example, 2/3 of India's population is under 35 years of age. That is 1 billion people out of 1.5. And also about half of our population is under 25 years of age. That is more than 700 million people. So the dilemma, the challenge is to balance the needs of younger population, because younger populations need employment, education, career support, etc., etc. And today's younger population is going to be tomorrow's older population. And being healthy is important for them as well. And of course, older people's challenges, which are growing in numbers. And of course, as people age, their health needs are more complex and more demanding. So this dual demographic challenge is very characteristic for India, and this is going to continue to impact our health policies and programs for many, many years to come. And then secondly, the challenge which is very relevant to India, to our communities that we work, and also to the neighboring countries in the South Asian region and to parts of Africa, is this double burden of disease. All over the world, the prevalence of non-communicable diseases such as diabetes and cancer is growing. That is seen in all parts of the world, in all types of income status countries, high income or low income countries. But countries like India are also home to a large number of communicable diseases as well, despite of the advances that have been made in prevention, in treatment of communicable diseases. India continues to have a very large number of communicable diseases rates. There is a lot of TB, for example. There is a lot of malaria and other communicable diseases. So this double burden impacts the population very significantly. And the discussions that we are having at the country level and as well as at the global level is highly tilted towards non-communicable diseases. Rightly so, there is no dispute, there is no denying that non-communicable diseases are of vital importance in terms of public health thinking. But we haven't really reached a position, a place like high income countries have reached, where communicable diseases are not anymore a problem for the nation. We still have a lot of communicable diseases, and unless we take a balanced approach between the two sides of the health thinking, adequate amount of progress will not be made on health and well-being. And then I also believe that there is a lot of transformation that is taking place in terms of digital technology, in terms of virtual trainings and capacity building opportunities. Telemedicine is coming up quite a bit. And that, on one hand, provides a wonderful opportunity.
Mm-hmm.
On the other hand, it becomes an even bigger obstacle, barrier for the remotely located populations because they are deprived of digital technology.
Yes.
So the digital divide is getting wider and wider. It is including people into treatment programs, but more than inclusion, it is excluding a lot of populations from health programs, particularly older people, particularly women who are less educated than men in rural and remote areas. And because we are such a predominantly rural population, 2/3 of our population continues to be rural, and that will not change. That will continue to be the case in the years to come. I think this digital divide also needs to be looked into, must be bridged. Otherwise, the challenges will grow even further. So multiple barriers that are affecting our public health approach, and therefore, again, comprehensive thinking is required.
So, when you say approach, so could you share any kind of innovative approaches which Gravis has implemented that could serve as a model for similar settings worldwide, maybe in India, in other states of India?
There are multiple experimentations that we have done within our programs, within our work, which might be worth looking at. I did talk about population aging as one of the most significant phenomenons of the 21st century.
Yes.
And the world is getting older and older, but people don't get old suddenly. People don't get old overnight. It's a process which happens throughout the life, and therefore very strongly we are realizing, we are understanding that the life course approach towards aging is important, which means that people start getting older when they are younger. And therefore a continuum of activities, a continuum of services is required. Keeping that in view, we have been experimenting with an activity, with an intervention called intergenerational learning groups. We call them ILGs.
Okay.
And the idea is to bring younger people, mid-age people, and older people together to have exchange of knowledge, to have exchange of ideas in the context of health, but also in the context of livelihoods and income security and other aspects of life which are directly and indirectly linked to health and well-being. What happens as a result of this kind of an exchange, there is a greater solidarity between different generations in the communities, which is actually quite kind of dwindling in the age of internet and more importantly, post-COVID. So there is a sense of greater solidarity, there is a sense of knowledge exchange, and the knowledge exchange is not one-sided. The knowledge is given by both younger generations to older generations and from older generations to younger generations. So keeping life course approach in view, keeping healthy aging in view, which is a lifelong process, we believe that intergenerational approaches are going to be important. What we are doing is yielding some very, very significant results. and we are very excited about the progress that has been made. The other innovations that come to my mind, we have been doing a lot of work on adolescent health, which we believe is a critical pillar of sexual and reproductive health in people's lives. The understanding of puberty, of health issues in that age, uh, in the context of future sexual reproductive aspects of life are critically important. And most of the boys and girls are not fully educated, not fully aware. And of course, there are cultural reservations and there are a number of restrictions that come into the way.
Yes.
So we have been leading this program in which we are training and teaching adolescents in different groups with the cultural aspects in the mind, the trainings for boys and the trainings for girls that have been extremely successful and extremely relevant for the local communities. So that's an idea which has also been replicated in some other organizations' work that we worked with. Gravis also works quite extensively on food security and water security, which are such important prerequisites for health and well-being. Water security, for example, is one element of our work in which we have been doing a lot of work on the quantity side of water for a very long time, ensuring that there is enough water for people to consume, for people's sanitation needs and livestock needs. But then later on, as we grew, as we evolved, we started realizing that it's the quality of water also which is critically important, not only the quantity, because the water quality, of course, leads to a number of both communicable and non-communicable diseases.
Yes.
So we have actually been innovating quite a lot with water filtration techniques, techniques that are affordable for firstly, because people can't afford to have very sophisticated filtration equipments and also easily managed, maintained by the communities. So we have been working on biosand water filters for about 15 years now, and we have done a lot of work in training and capacity building of the local communities on how to assemble these filters, how to make these filters. They are not made in the industrial setups. They are made by people themselves, and they are used by people. It's a wonderful innovation that we have come across, and we have documented its evidence with data and with success stories, and we have found that the use of these low-cost filters has actually been quite instrumental in reducing the prevalence of waterborne diseases very significantly, which is good health and well-being for the local communities. There are a number of innovations that have been very successful, but in the context of innovations, I would just like to add is that innovations are important. Innovations are always going to be a part of our approach as in Gravis approach, our approach as in a collective idea for all civil society organizations and for our entire community. But then there is already a lot of good practices, a lot of good knowledge which exists. And oftentimes that set of best practices, that good inventions remain unutilized, and that's not fair. So the pursuit of innovation is important, but it's also extremely important that the innovations that have already taken place and that have been successful are fully utilized, their potential is fully realized. And therefore, in that context, learning and exchange, partnerships, dissemination of programs, these are extremely important components.
We extend our gratitude to Dr. Prakash ji for joining us on this episode. Thank you so much, sir, for giving us the opportunity to learn from your experiences and expertise. Your dedication and perspective to the community health and the transformative work being done at the grassroots level, reminding us of the power of collective action and innovation. We look forward to following your continued efforts and contributions to the communities. Thank you.
Thank you for inviting me.